Hello. A very warm welcome to all joining our webinar today. Distinguished guests, friends, colleagues, champions of health and gender, specialists joining us from around the world. My name is Mirat Khalil. I'm with Women and Global Health Egypt, and it's my immense pleasure to welcome all of you to this high-level event, co-sponsored by the Government of France and the Government of the Democratic Republic of the Congo, Africa Centers for Disease Control, and Women in Global Health. Throughout this 90-minute webinar, we want to hear from you. So please introduce yourself in the chat and feel free to send your questions to the speakers and also tweet using the hashtag shared in the chat. Make sure that you're sending your messages to everyone and not just the panelists. There's also an option to adjust the setting in the chat box. As health ministers meet this week during the historic 75th World Health Assembly, and with the COVID-19 pandemic far from being over, it's more important than ever to bring to the forefront the critical issue of health workers, especially that 70% are women. Last year, France, the WHO, and Women in Global Health launched the Gender Equal Health and Care Workforce Initiative, which you will hear more about today. Under this initiative, governments, international agencies, and NGOs joined together to address the gender inequalities in the health workforce that are bad for women, health workers, and also health systems. Today, we will hear from inspiring women and men from governments, NGOs, and communities on the subject of safe and decent working conditions for women, health and care workers in times of crisis. Let me now introduce our first distinguished speaker, Dr. Martin Obalo, who will give us an introduction to Women in Global Health and the organization's work to highlight the importance of safe and decent working conditions for women and health and care workers. Dr. Obalo is the Managing Director of Women in Global Health and has decades of experience in the fields of both public and global health. She was the Minister of Public Health in her home country, Guinea-Bissau, and one of the only women in the world to lead a national COVID-19 task force. She has also worked extensively with the World Health Organization. Dr. Martin, the floor is yours.
Thank you very much, Meredith. Good morning, good afternoon, and good evening to everyone. On behalf of Women in Global Health, it gives me great pleasure to welcome all our eminent speakers, our moderator, and audience for this event today, which marks the 75th World Health Assembly taking place this week in Geneva. Today is also Africa Day, and I want to wish us all a happy Africa Day as we continue to work toward a healthier, more equal, and prosperous continent. I bring you warm regards from our Executive Director, Dr. Rupert Das. I want to thank our partners in this event, namely the governments of France, the Democratic Republic of Congo, and the Africa Centers for Disease Control and Prevention. In the third year of the COVID-19 pandemic, as the world's health ministers convened in Geneva for the 75th World Health Assembly, it is the right time to reflect on our theme today: safe and decent working conditions for women, health, and care workers in times of crisis. I want to start today with 4 truths. The first truth is there are no health systems without health workers, and we are seriously short of health workers globally and in Africa in particular. The second truth is that there are no health systems without women. Women are 70% of health workers globally and 90% of nurses and frontline workers. The third truth is that the majority of women health workers did not have safe, decent, and equal working conditions before the pandemic. The pandemic has exposed and widened inequality. We had a long way to go to close the equity gaps in 2019, and today we have even further to go. The fourth truth is that we cannot build strong health systems, societies, and economies without closing gaps in equity. And that includes safe, decent, and equal work for the women who largely deliver our health systems. Driven by these four truths, Women in Global Health were proud to launch the Gender Equal Health and Care Worker Initiative with France and WHO in 2021, because we recognize that health systems cannot function without the work of women. At the same time, we recognize that the extraordinary service of women health workers in the pandemic and before has not earned them an equal say in decision-making. Therefore, the Gender Equal Health and Care Workforce Initiative that Women in Global Health lead with France aims to inspire action for gender equity in the health sector in 4 pillars. The first pillar is about promoting equal participation of men and women in health leadership. The second pillar is about recognizing the value of unpaid work, largely done by women in the sector, and the importance of equal pay. The third pillar of the Gender Equal Health and Care Workforce Initiative is about protecting women health workers against violence and harassment. And the fourth pillar is about ensuring safe and decent working conditions for health and care workers everywhere. I'm pleased to note that in just over a year, the Gender Equal Health and Care Workforce Initiative has convened the international community, focused attention on the critical issue of gender equity in the health workforce, and that over 40 governments, international organizations, and NGOs have expressed their support. We thank all the governments and organizations that have joined the initiative, with special thanks to the governments of Ethiopia and Malawi, and the American Medical Women's Association, both joining the initiative today. COVID-19 is our opportunity to rebuild global health on a stronger and more equal foundation, and ensure that the women who deliver health are leading the systems they know best. But after surging patient numbers, significant health risks to themselves and their families, and an increased burden of unpaid work at home, health workers are burnt out, and many are suffering exhaustion and mental trauma. Women health workers have been hardest hit because they have been the majority of health workers in patient-facing roles as nurses and community health workers. We see a great resignation of women health workers in high-income countries underway, which will increase the risk of unmanaged migration of health workers from low and middle-income countries, further undermining health systems in countries struggling to reach universal health coverage. This week, the Global Burden of Disease published its Human Resources for Health study, concluding that in 2019, over 43 million more health workers were needed to reach universal health coverage. This includes an additional 30 million nurses and midwives. The largest shortages of health workers were in Sub-Saharan Africa, South Asia, North Africa, and the Middle East. And please note that these staggering figures are for 2019, before the start of the pandemic. And since then, health workers have been lost to the virus and to longer-term complications from COVID-19. I return to my 4 truths. There are no health systems without health workers, and the default health worker is a woman. All our efforts towards universal health coverage and global health security will fail if we do not address the mental well-being, protection, and human rights of our own health workers, particularly women. Gender equity in the health workforce is central to strong health systems and global health security, and will continue to work with France to build the initiative until gender equity in the health workforce is a top political priority for action. We invite your government or organization to join us in the Gender Equal Health and Care Workforce Initiative, so together we can escalate this to the highest political levels. We need to do more and to do it urgently to meet the crisis that we face. Women health workers need a new social contract that recognizes and values their contribution. With decent work, safety, fair pay, and equal opportunities for career advancement and leadership, women health workers will be free to deliver the best possible health services for everyone. This is everybody's business. So I thank you once again for joining us today, and please join us on the next stage of this journey. Thank you.
Thank you so much, Dr. Obalo. As always, we are deeply inspired by your leadership, and we commit to keeping these four truths in mind as we advocate for gender equality during this World Health Assembly. Now, I would like to invite Her Excellency, Minister of Health, Dr. Liya Tades, from the Federal Democratic Republic of Ethiopia. Appointed in March 2020, the Honorable Minister has been at the forefront of her country's response to COVID-19. She is a physician who specializes in obstetrics and gynecology, with extensive experience as a clinician, academician, policymaker, and executive leader. The Honorable Minister is currently the co-chair of the COVAX ANC Engagement Group of the Global Financing Facility for Women, Children, and Adolescents. Honorable Minister, the floor is yours.
Thank you very much for the kind introduction. Distinguished participants, ladies and gentlemen, Dr. Magda and all WGH team. It gives me a great pleasure to join you today on discussing on this important topic on safe and decent working conditions for women, health and care workers. Women's equality and empowerment is critically important for the sustainable development goals we all envision. And in recognition of this, Ethiopia is a signatory to the multiple international and continental conventions and declarations that support women empowerment and gender equality. And we are making notable progress, some notable progresses towards this the equal representation of women at the higher leadership level, with the ministerial cabinet being 50% female since 2019 and 39% of the parliamentary seats being by women. As minister, as a woman, and with the full support of the cabinet, I'm working with my team to achieve the SDG 5 goals to the health sectors, where we are considering the specific needs of women and girls as both providers and recipients of care, therefore critical to achieving universal health coverage. Women, their knowledge, perspectives, and expertise needs to be included in the health decision-making. And it is through equal representation that governments can harness the invaluable insights that women hold. That is why, as a country, we're committed to ensuring women's representation at all levels, with merit-based assignment to different levels of the health facility, with appropriate professional and gender mix. To develop the pool of emerging leaders, our Ministry of Health is implementing a leadership incubation program which enrolls 60% women participants. But we all agree gender equality goes beyond leadership and representation of women in key roles. The ministry has effectively integrated a gender perspective into all aspects of health system and national strategies. Our health sector strategic plan, developed with meaningful participation from both women and women since launched in 2021, includes actions to address gender, geographic, and socioeconomic disparities. Similarly, the Ethiopian Human Resource Development Plan strives to create and ensure a safe and respectful environment, zero tolerance for sexual harassment and abuse providing daycare facilities, and as needed, providing mental and psychosocial services to our health workers. And unpaid voluntary work in core health system roles, mainly carried out by women, also must be valued and rewarded. And this reflects our commitment to WHO Resolution 72.3 on community health workers that Ethiopia introduced also in 2019. Ethiopia recognizes the huge role played by our health and care workers globally in the ongoing pandemic prevention, preparedness, and response throughout these 2 years. And the government has been trying to add additional healthcare workers into the system so that they can give the needed care without burnout. But these efforts are not without challenge and require strong political commitment, and we have to do more. Distinguished participants, let me turn our business also to our business here at the WHO. Ethiopia has had the pleasure of co-chairing a member state-led process for the new Working for Health Action Plan. This updated action plan from now until the end of the SDG period in 2030 builds on the success of previous recommendations from the UN High-Level Commission on Health, Employment and Economic Growth in 2016. And I'm very pleased to confirm that this new plan includes a deliberate focus on gender and women in the workforce, applying many of the same principles and commitments we are striving to mainstream in our country. And I urge you all to read it and use it and apply it in all our respective settings within, of course, our contexts. Finally, I also hope and wish that next year, in the next year's assembly, we'll come back with evidence and results from what we have done to advance this agenda and its impact in our health system, and ask for all of us to lead the change and not to wait for it. I thank you.
Thank you so much, Your Excellency, for your informative and inspirational remarks. I now have the pleasure of introducing Ms. Lois Pace, the Assistant Secretary for Global Affairs for the U.S. Department of Health and Human Services. She is responsible for advancing the U.S. international health agenda through multilateral and bilateral fora, including high-level institutions such as G7, G20, UNGA, and the World Health Assembly. Ms. Pace, the floor is yours.
Well, thank you very much to Women in Global Health and also to the government of France for highlighting this critically important issue. I'm grateful to follow the other speakers, and we'll try to offer some additional thoughts and insights on the topic at hand. As has been mentioned, we have truly experienced a lot in this pandemic, which includes the disruption of essential and critical health services. And those health services have really been managed and led by the important role of health workers, many of whom are women, and in fact, 3 out of 4 in the healthcare workforce we know are women. We also have a childcare workforce, 9 of 10 of whom are women, and often they are not regarded as actors on the front lines as well, and yet they have played an incredibly critical role in keeping our communities safe and whole. And so I want to start by acknowledging sort of who makes up this workforce, as has been mentioned, and also recognize, again, the unequal burden that's shouldered by the women in this community. It's quite something that these women have taken on, a disproportionate amount of work compared to men when it comes to providing this care and providing these services, and particularly to have that work go unpaid or undervalued, which is something that we in the US government absolutely want to change. But before I get into how we are working towards those changes and hoping to work with many of you, I also have to call out a number of other sobering statistics we've seen, particularly in the pandemic, physical violence and attacks on those who work in the health and care sectors. Between 10 and 38% of health workers experiencing this type of violence, which has been estimated by WHO. Healthcare workers are also 5 times more likely to experience workplace violence than workers in other industries, and this includes threats and harassment that have now expanded online, including through social media. And I have to say that this is something that even I have experienced, and I can only imagine those who have greater and stronger experience with these types of online attacks. It's not something that I wish upon anyone, certainly not people who are doing what they can to save lives. This, of course, in addition to just working day in and day out, can lead to a real strain on mental health in the workforce and can lead to burnout. Unfortunately, we also have seen rates of suicide climb in the healthcare community. And so given all these things, we are really keen not just to celebrate our workforce, but to support our workforce in the US and again, across health and healthcare, but also care more broadly speaking. We need to pay people fairly, we need to treat them equitably, and we need to protect them as much as possible. So a number of you might be aware that the US recently launched a global health worker initiative to this end, and it's intended to do just that, to really address the needs of the workforce, given what they continue to face. There are 4 key pillars that we outlined as part of this initiative. And first is around protecting health workers, but also second is around creating jobs and economic opportunity. We also have a clear commitment to driving technological innovations and advancements that support and improve the work of healthcare workers. And then finally, it's our aim to advance equity and inclusion. We're quite proud of the Health Worker Initiative and grateful to the many stakeholders that helped inform this initiative. We also look forward to partnering or otherwise aligning with additional initiatives and efforts that have been or will be discussed today. We're hopeful about the opportunities this provides across the health workforce in both public and private sectors, and also how it can work to importantly improve the services and impact these workers have around the world. Finally, I will just say that all of our actions are intended to not just bring health workers into the workforce, but to keep them there and to do so in a way that honors their efforts and ability and ensures that they have the highest and best use in the communities they serve. Ultimately, we want this workforce to be resilient, but not at a cost to themselves. And I think that's important to keep in mind, that people should be able to serve in this capacity without giving themselves so completely that there's nothing left for the individuals or their own families. With appreciation, again, we're glad to be a part of this event. We certainly applaud the work of health and care workers worldwide, but again, it's more than accolades we need to offer them. We need to ensure that we're showing up for them in the way that I know this group will continue to do. So thank you again to Women in Global Health for hosting this event and for having me join you today. And my regards to the other hosts and speakers. Thank you.
Thank you very much, Ms. Pace, and thank you for your advocacy for gender equality in health. I would like to now introduce a video message from His Excellency, the Minister of Health of the Democratic Republic of the Congo, Dr. Jean-Jacques Mbana. His Excellency, the Minister, is the Minister of Health, Hygiene and Prevention for the government of the DRC. He leads the Universal Health Coverage Project within the government. And could we please load up the video?
Excellences, Messieurs et Dames les ministres, et chers conférenciers de ce jour. C'est pour moi un grand plaisir, au nom du gouvernement de la République démocratique du Congo, de me joindre à cet événement important aujourd'hui et d'exprimer le soutien de mon pays à l'initiative sur la place des femmes dans le secteur de la santé et des soins. Je remercie la France et Women in Global Health d'avoir organisé cette initiative. Nous sommes heureux de nous joindre à d'autres gouvernements et organisations internationales dans cette initiative pour soutenir une plus grande équité et de meilleures conditions pour des femmes dans le personnel de santé. Au cours des dernières années, nos personnels de santé, et en particulier les femmes, au niveau communautaire, ont apporté une contribution exceptionnelle face aux urgences sanitaires et aux pandémies, notamment l'épidémie d'Ebola, la rougeole, la Covid-19, en plus des autres problèmes de santé qu'elles gèrent régulièrement. La distribution inéquitable des vaccins dans le monde a laissé nos personnels de santé sans protection dont ils avaient besoin pendant la pandémie. Nous devons veiller à ce que les enseignements tirés de cette pandémie et des autres urgences sanitaires dont la maladie à virus Ebola soient appliqués à l'avenir pour mieux protéger tout le personnel de santé. Nous rendons un hommage vibrant à leur service et soutenons pleinement les objectifs de l'initiative visant à permettre aux femmes d'assumer une plus grande responsabilité et un leadership avéré dans le service de santé et à leur garantir des conditions de travail sûres et décentes. La pandémie nous a montré à quel point nous dépendons du travail des femmes dans le secteur de la santé. Au travers de cette initiative, la République démocratique du Congo, mon pays, travaillera avec vous pour soutenir toutes les initiatives visant à valoriser le travail des femmes dans le secteur de la santé. Je vous remercie.
Special thank you to the Honorable Minister for taking the time to record this video. We greatly appreciate the support and the continued advocacy for gender equality. Next, I am pleased to introduce Dr. Salima Rahman. Dr. Rahman was the 2021 regional winner for UNHCR, the United Nations High Commissioner for Refugees, Nansen Refugee Award. Dr. Rahman lives and practices medicine in Pakistan, where she became the first ever female Afghan refugee doctor of Turkmen origin. Dr. Rahman will speak about her work on the front lines of the COVID-19 response, particularly in humanitarian crises. Dr. Rahman, the floor is yours. Dr. Rahman, are you on the call? Dr. Salima, we try one more time. Okay. Until the technical issue is resolved, I think we move on to the next speaker. Next, it is our honor to introduce the Honorable Minister, Her Excellency, the Minister of Health of Malawi, Dr. Kulumbi Chiuponda, with a video message showing her support for the Gender Equal Health and Care Workforce Initiative. Can you kindly please load up the video?
Your Excellencies, Honorable Ministers, Speakers, Panelists, and our esteemed audience, it gives me great pleasure on behalf of Government of Malawi to join this important event today. It also gives me great pleasure to express the formal support of the Government of Malawi for the Gender Equal Health and Care Workforce Initiative. I thank the Government of France and Women in Global Health for convening this important initiative. Women health workers play a critical role in the health of our communities, but also in our economies. We are now in the third year of the pandemic that has stretched health systems everywhere to the limit. At the start of the COVID-19 pandemic in Malawi, we were short of PPEs, we were short of oxygen, and also short of critical health workers. vaccines were very slow to reach Malawi. Our health workers worked with great courage and commitment with limited protection and resources to manage COVID-19 and also to put in place public health measures and finally to deliver the vaccines when they became available. They also worked to keep all other health services open since issues like pregnancies and other conditions do not stop for a pandemic. I want to pay tribute to all health workers in Malawi and also across the globe, especially the women community health nurses, the midwives, the health surveillance assistants who provided critical interface between health systems and communities. We are pleased to join with other governments and international organizations in this initiative to support great access to leadership for women health workers, better protection, and indeed better conditions for the women in our health workforce. We are concerned that the pandemic has worsened the global health worker shortages that already existed in countries such as ours, Malawi. We will work with other governments through this initiative to take a global view to ensure that we can retain our women health workers and also attract more into the profession as we build resilience and fair health systems for the future. In the last few years, our health workers, particularly women at a community level, have made an exceptional contribution in the face of health emergencies and also pandemics. We pay tribute to their service. The pandemic has shown us how much we rely on the work of women in health. As the government of Malawi, we are committed to working with all of you to support and protect our women who deliver health services for our communities. I thank you.
A special thank you to Her Excellency the Minister for that expression of support for the Gender Equal Health and Care Workforce Initiative. Next, I would like to invite the next video from Dr. Padmini Murthy, Global Health Lead for the American Medical Women's Association. Dr. Murthy is a professor and Global Health Director at the New York Medical College School for Public Health Sciences and Practice. She's currently the chair of the International Health Section of the American Public Health Association. Can we kindly cue up the video?
Of the American Medical Women's Association, which is 106 years old, I am Dr. Padmini Murthy, Global Health Lead, and it is indeed an honor and a privilege for American Medical Women's Association to support the Gender Equal Health and Care Workforce Initiative launched by the government of France and Women in Global Health and other partners. This is a landmark initiative since it aims to promote equity for women in global health leadership. I would like to just reiterate 2 years ago at the start of the global pandemic, what Secretary General Guterres said. Antonio Guterres very rightly said, gender equality and women's rights are essential to getting through the pandemic together, to recovering faster and building a better future for everyone. He also stated that women have to be in leaders and with equal representation and decision-making power. This starts with women at the helm. Unfortunately, even though for the past 2.5 years, women have been serving at the forefront of the struggle against the virus in multiple roles as doctors, nurse practitioners, nurses, caregivers, frontline workers, or at the political organizational helm. In this contribution, it is like really not being recognized. That is the challenge we are facing. And not only in their own communities, their families, their countries, but the whole world as such, women have been at the forefront in promoting global health, but they have not been recognized as leaders. They are not being given a seat at the table as much as their male counterparts. So this initiative hopefully will address this and make sure women are in more leadership positions. As we know that by collectively including women in global leadership, we can promote the health and well-being of the communities, promote the sustainable development goal targets, and also universal health care. We all need to join together as a team to make sure everybody has a seat at the table and in decision-making when it comes to addressing women's health and having women leaders in global health, because only when there is gender equity can we have better health coverage. And it is so important, especially now, post-COVID, for universal health coverage. So we need to do whatever we can to work together as a team to promote health and well-being for the communities we live in and serve. Thank you.
That was a wonderful video. Thank you again for your advocacy and your support in advocating for women's leadership in health. Next, I have the pleasure of introducing our high-level panel. Our first panelist is Dr. Sumiga Astana, a postdoctoral research fellow at the Center for Global Health Science and Security. She is the co-lead of the Women in Global Health India chapter. She's also a physician, a health administrator, and a health policy and systems researcher. She works at the intersections of global health governance, influence of development aid on national health policies, gender, and mainstreaming of alternative systems of medicine in public health. Our second panelist is Mr. Pintado Núñez, branch chair of the Governance and Tripartite Department of the International Labour Organization, the ILO. He has worked at the ILO's Decent Work team and country office of Central and Eastern Europe as a specialist on labor administration and labor inspection. Before joining the ILO, he was the head of the Planning, Strategy, and Technical Directorate of the National Authority for Working Conditions in Portugal. Last but not least, it's my honor to introduce our third panelist, Dr. Mohammed Abdelaziz, the head of Surveillance and Disease Control Division for Africa CDC. Dr. Mohammed is a medical doctor and has a master's in public health. He is a fellow of the West African College of Physicians and was the chief consultant physician before joining Africa CDC. Each of our esteemed panelists will have 3 minutes to give an opening statement on the theme of the event, followed by questions. So let's start with our first panelist. Dr. Astana, the floor is yours.
Thank you. I want to thank you for inviting me, and it's an honor to be here today among the esteemed speakers, panelists, and participants. The opening session of this assembly, Dr. Tedros announced the Global Health Leaders Awards, the polio workers in Afghanistan, and the ASHAs, the voluntary health workers in India, to recognize the important work they do. It's been a great achievement and a great recognition for the health workers. However, the health workers in many parts of the world continue to work in the conditions of low pay, unsafe conditions, lack of proper grievance redressal systems, feeling marginalized in the decision-making roles, and of course, a very little recognition of their expertise and knowledge. I want to just make a statement that it's time to move from these accolades and awards towards more action, towards more solutions to address their issues. I want to make 4 quick points after hearing these esteemed speakers today, and we all are aware of the unsafe conditions, but probably it's time to expand who we refer to as health workers, to include those workers who are traditionally not seen as the part of the health systems, the volunteer workers, the informal workers who are contributing to the healthcare work. Just as for the definition of health systems to include all actions towards health, promoting health, we need to be inclusive about the idea of health workers to include voluntary workers, workers from the other sectors who are continuing to do the healthcare work, including the childcare workforce, including the self-help groups who've been engaged in relief work, including the elected representatives, the school teachers, the allied health professionals. I would suggest to include in the idea of health workers anyone who's performing an act towards either detection, surveillance, treatment, or even relief work as required by the government, and classify them as health workers and provide them the similar safety and protection measures as we provide to what we traditionally understand as health workers, whom we traditionally understand as health workers. My second point is on safety, and safety, again, let us expand this focus from just the safety from infections and diseases to safety from violence, from stigma, from burnout, and from exhaustion. We've seen the instances of physical violence on health workers when they were engaged in surveillance activities or asking people to go into quarantine facilities. We've seen them facing stigma of being infected and being called super spreaders because they were the most exposed. We've seen them getting socially boycotted from their families and communities. And we're talking about these workers who in regular conditions walk many miles, even cross rivers to provide health services. Their safety becomes even more important in the situation of health emergencies. My third point is that we should have different strategies for different categories. Though our idea of health workers need to expand, clubbing these different categories of workers while devising policies might not work. These workers work in different settings, different contexts, have different nature of contracts with their employees. Few have institutional structures to be supported, few others do not have, few are just voluntary workers with absolutely no support. So tailored policies for their context are needed. And most importantly, the policies need to be tailored to the context of the countries. While it's easy to say to provide extra remuneration, extra safety measures and resources, provide transportation services, and extra safeguards, we need to be aware that the most vulnerable workers are situated in the weakest health systems. These health systems are often poorly financed, poorly regulated, poorly governed. We need to come up with more innovative ideas to address the concerns of safety of workers in the resource-poor settings. Though the idea of decent work and safety measures might mean the same in theory, in practice, it may mean different things. However, the least minimum standards of safety and decent work should be set as non-negotiable. Thank you.
Thank you very much, Dr. Astana, for your insightful remarks. You're very correct in saying that the health workforce is a very dynamic and complex issue, and this dynamic nature should really be kept in mind when discussing this at policy level. Next, I would like to invite Mr. Nunes for your opening remarks. I kindly ask that you would keep your remarks to 3 minutes. Thank you.
Thank you so much, and thank you for inviting the ILO for this event again. I start with the words used by Dr. Astana, that as a matter of fact, there is no decent work without safety and health at work. And as a matter of fact, back in 2019, when the ILO started looking into the future of work, it has declared that safety and health at work is fundamental to decent work. So we know that the health system, well, the health sector has been and is still being severely affected by the COVID-19 pandemic. This is not new because this was the case already when we had other public health crises. And we have to face it, the health sector is a hazardous sector. Workers, both women and men, and of course we also have to consider the gender dimension, are exposed to all sorts of hazards, biological hazards, chemical hazards, physical hazards, and of course psychosocial hazards, and not forgetting violence and harassment. And some of the previous speakers already referred to the serious risk of physical and mental threats that will affect the health of these workers, immediately or in the long run. So what in the ILO we advocate for is that any kind of approach to safety and health at work has to be universal. It has to be universal in the sense of, looking into all the sectors, looking into all groups of workers, including and in particular those that are most vulnerable. And again, coming back to what Dr. Astana said, including those that are in precarious work arrangements and also in the informal economy. And again, what the ILO offers is a normative framework. So a set of international standards, which are international treaties that are ratified by member states, and that when it comes to occupational safety and health, for example, oblige ratifying member states to define national policies, set up national programs, and also set up national systems that need to encompass all the elements for these systems to be universal, again, addressing all the different sorts of hazards, all groups of workers, and all the sectors. And just to finish my intervention, there is something happening now in the ILO, and in the upcoming 2 weeks, we may have a decision that will declare that safety and health at work is one of our fundamental principles and rights at work. And this is a major game changer that will affect the protection of all workers worldwide, because it means that all of our 187 member states, independently ratifying or not ratifying our conventions on OSH, the ones that will be declared fundamental, will have the obligation by the fact that they are members of the ILO to respect, to promote, and to realize the right of all workers to safe and healthy working environments. So I hope that in a couple of weeks, I'll be able to announce that, as a matter of fact, safety and health at work is now fundamental. And I hope that this will be, a very important step to accelerate progress in terms of protecting the well-being of all, and as a matter of fact, the right to life. Thank you.
Thank you very much for highlighting this very important point regarding the safety and well-being and resilience even of frontline workers. I'm sure we will discuss this extensively in the panel. Without further ado, I'd like to invite Dr. Abdulaziz for opening remarks. The floor is yours.
Thank you so much. It's a pleasure to be here representing the outgoing Director of Africa CDC, Dr. John Nkengasong, and the incoming one, Dr. Ahmed Ogwell. So good morning, good afternoon, and good evening to all distinguished participants of these discussions. We all know that gender issue is a big problem when it comes to workers, healthcare workers, and nowhere is this seen more than in the cadre of health worker called the community health workers. Let me say that Dr. John Nkengasong supports this initiative, Gender Equality and Healthcare Workers Initiative of this group, and Africa CDC will be part of this and every other initiative on ensuring gender equality among healthcare workers. In the community healthcare system, 70 to 80% in some cases are women. And we all know that the work they do it even better than some other cadres, because they are in the community, they are respected by their folks and other colleagues, and can do what others may not be even be able to do. But they are the lowest paid. Sometimes they are not paid at all. And they do not have even grievance ways to, because it's informal, so to speak. They do not have ways of reporting harassment, reporting violence, and they are not, like the previous speaker said, because they are not even considered as health workers. They do not get access to grievance mitigation processes that you get among other health workers. So all of these things that the Africa CDC is trying to remedy by working to standardize and improve the process of community health workers on the continent as we speak. This include working to, like I said, to standardize the community health worker cadre and make it a more formal approach where there is SOP for compensation and even for how a career progression, because it's not just by chance that where we have women dominating, career progression is not well organized. So these are some of the things, including when it comes to leadership in health, trying to ensure that there is some equality in terms of intake into leadership position. To this end, Africa CDC is setting up the Kofi Annan Fellowship. More than 50% of the fellows, that the foundation fellows that just graduated, were women, and more than 50% of those coming in the cohort 2 are women. And this is a way of boosting the women leadership in the health workforce on the continent. Let me stop there, and maybe when we get to question and answer, I'll be able to provide more details. Back to the chair.
Thank you very much. We really do appreciate your commitment and your support to advocate for gender equality and safety of health workers for all cadres, from community health workers to nurses to physicians to frontliners, and really this is quite honorable. So let us begin with our panel discussion. So in the interest of time, I will be merging a couple of the questions, but really we're keen on hearing your insights, and we'll go in the order of the introductions. So let's start with our first question. From your perspectives, how can we ensure that health workers, particularly women, have safe and decent working conditions in health emergencies? What we saw from the pandemic is really there are high levels of stress and burnout in the health workforce, which is contributing to issues of retention. So it would be, we are keen to hear from your perspective. So let's start with Dr. Astana, the floor is yours.
Thank you. I think it's such a broad question and a bold attempt that we're looking at here. So our solutions, our recommendations and ideas have also been very bold. I think the changes are needed at all levels, at the broader policy level, at the national levels, global levels, supranational levels, and supra-international levels, as well as the institutional and the organization level, as about going downwards towards the employers and the employees and the mindsets and so on. So I'm not going to repeat what my colleagues at ILO and the WHO have been advocating for. We have the safety charter. We have wonderful work coming from ILO in actually how to do this. But what I want to highlight is that there are structural as well as mindset changes needed. We need to recognize the importance of safe and decent working conditions, not just based in the health systems, but also in terms of the contributions of women to both health systems and economy, as well as their right to safe environment and decent work. And while we have wonderful work at the policy level and wonderful policies, I think the challenges are more at the level of institutions and individuals. These are more challenging given the male-dominant society and the male-dominant leadership in which we all operate. There's clearly a lack of representation of women in the decision-making roles. There's clearly a need for change at the structural levels and the way we operate, our cultural preferences and mindset that we bring into our workplace as well. So I'll just stop there to say that those are the changes that we need to highlight. And those structural changes are also situated in the broader political economy of the health systems in which they operate, the broader economic situations and the political situations. Thank you.
Thank you for your intervention. I'd like to give the floor to Mr. Nunez to highlight really what can we do on protecting health workers, not only physically, but also mentally. How can we really improve working conditions for frontliners, especially in emergencies? The floor is yours.
It was muted. So I would highlight three different levels. One is the workplace level, and let me also address the gender dimension. At the workplace level, we need to, well, first of all, empower all workers, and in particular women, so that they are part of the process so they are consulted, and they are also part of the solution. So it's very important that workers, and again, in particular, women workers, are part of the structures that, for example, represent the interests and the rights of workers. And I'm speaking here of workers' representatives in general, unions, workplace OSH committees, so that the gender dimension can really be a part of the management of occupational hazards in workplaces, in all workplaces, public and private. Then the legal dimension. So we need to make sure that the laws, as a matter of fact, apply to all workers, independently of the work setting and the type of contractual relationship they have with the employer. And again, and this was already mentioned, that sometimes this is not the case, and sometimes the same law does not apply to all workers, very much because of the fact that, for example, sometimes they are engaged on non-paid work, or they are considered as informal service providers, or as self-employed workers, to which the same rules on safety and health do not apply as to other workers. Then, of course, the most difficult one, cultural changes. So we need to make sure that, of course, we all know that there is an interlink between safety and health at work and what happens in communities and in our private life. So there is a need to, evolve culturally in terms of having a better distribution of jobs or of tasks also at home when it comes to women and to men, so that there is not this proportionate and imbalanced distribution of work, especially and responsibilities in many countries still, especially when it comes to taking care of our families. So this is very, but that of course will take some time. Thank you.
Thank you very much. Dr. Abdulaziz, the floor is yours.
Thank you, Chair. Thank you, Chair. So let me not repeat what the previous speakers have said, but to summarize it, that whichever level we are operating on, there are some key things that needs to be done to protect women during emergencies and healthcare workers during emergency situations. The first one is that we do not need to wait for emergencies to put in place standard operating procedures, to put in place safety guidelines, to put in place structures and mechanism to ensure safety and to ensure women are protected in their place of work. We need to make this very clear before emergency and have the structures on ground and let the workforce people, both everybody, to know that these things will work and there is a grievance pathway for women to be protected in their work environment. Whether we're dealing with emergency response, whether that's public health emergency response, or we're dealing with humanitarian disaster and what have you. This has to be very, very clear prior to emergency. Then training, very important. We need to train this workforce, women, community health workers, on how to go about to ensure that they protect themselves in their workplace. They can get sick to be able to do the right thing and grievances and know that they will be listened to. We all know that, especially in the part of the world where I come from, it's a male-dominated community. And if you know that when you go there, you'll be laughed at, you'll be considered, no matter what you put, it's not going to work. So this confidence have to be put in place. Finally, to break and to ensure that all of these mechanisms we are putting in place work, we need to ensure equal opportunity in leadership so that women can be there when decisions are taken. It's not just that it's men all over the place. And some very important component that requires critical thinking and understanding may just come when a woman sits there and she understands what the other person at the other end is discussing. So SOPs and structures to be put in place prior to emergencies and training, and of course, increase gender equality in whatever level we're operating on. Thank you. Back to you, Chair.
Thank you very much for your intervention. I think you really raised some of the critical lessons that we've learned from the COVID-19 pandemic, specifically on what can be done to really improve safe and decent working conditions, specifically for women. So I'd like to give the opportunity to our other panelists to share a few lessons learned on what does that look like, really. If you can offer one or two main lessons that COVID-19 has taught us on protecting women healthcare workers. Let me start with Dr. Astana, please.
Thank you. Thanks to the previous speakers as well for laying this idea. There are many lessons, I feel, and I will not repeat on what many countries have done in terms of providing support, the occupational health side, the emotional health side, the conditional cash transfers, the providing of extra remuneration for extra work, the different rewards that have been given, different channels that have been created for grievance redressal, for dialogue, for including the voices of health workers in decision-making positions, in key policies, and so on. And there are ample examples, but not to say that it's been all perfect. There are many gaps there, but of course, few lessons to carry forward on. For me, the biggest lesson that the pandemic has shown us to manage the situations, to safety, to decent work and recognition is the lesson of solidarity. I think the pandemic has shown us how do we build solidarity, the different cadre of women, how they have stepped forward to be there for each other, to support each other, to raise the concerns and the voices of those who were at the lower rung, at the lowest position in terms of power in the health system. So I think that's something that we should take forward and build on. And this also has benefits for the health systems and health services delivery, the way women health workers on the ground have been working in integration, where this is unrealistic to achieve at the ministerial level. These health workers on the ground were working in teams and being there for each other. Thank you.
Mr. Nunes, the floor is yours.
So yes, I'd say that, and Dr. Mohammed said this as well. I mean, let's not wait for the storm. We need to be ready well beforehand. And what we have seen throughout the world and in so many countries and in so many workplaces, that workplaces were not prepared for emergencies. And this is because there wasn't enough investment on safety and health at work. And I'm not only referring to financial investment, I'm referring to investment in terms of capacities. So what we saw is, including in the health sector, that when it came to either dealing with the direct risk of infection, but also to the risks, especially on the mental health dimension, that we did not have specialized support to these workplaces so that they could prevent and mitigate the negative health effects of all of this. And for example, a while ago I said that when we deal with us, we need to deal with it within this systemic approach. What we saw, and this we released estimates on the global burden of disease together with WHO last year, and we saw that there is a clear interlinkage between excessive long working hours and heart diseases. And we know that in the health sector, and especially when going through a crisis such as the COVID-19 pandemic, this was a major problem. So again, our workplaces were not prepared well, and even those that were better prepared to deal with the risk of infection, when it comes to other risks, so we saw that that preparedness was not there. So a very strong message that we are trying to convey from the ILO already since the pandemic started is that we need to invest in occupational safety and health. Just to finish now, for example, we know that in developing countries, the specialized services to assist workplaces with safety and health at work, so the occupational health services do not cover more than 20% of the formal sector. not even speaking of informal work settings, which, by the way, we can also have in those small units providing health services at community level, which are not considered as being part of the formal sector. So just this would be my thoughts. Thank you. Thank you.
Thank you for unmuting. I think really the lessons that have been raised are inspiring. The lesson of solidarity that has been raised, if I can just select some key words here. The issue of training and capacity building, investing in the health workforce, in their skills, in order for them to be able to do their job and also protect their well-being. And I think really, as Dr. Abdelaziz, you started really with this very critical lesson, preparedness. We cannot start on preparedness in the middle of the emergency. And so let me just give the floor to Dr. Abdelaziz to add maybe one or two lessons, and then we move on to our next intervention, even though you started us already with the lessons learned, but please, the floor is yours.
Thank you, Chair. I really want to intervene in this so that we can learn some very important lesson. Pandemics will come again, and we need to learn from what we've done now. So in one critical lesson for COVID-19 is that in responding to pandemics, we should leave humanitarian corridors open, because it's clear that when you apply interventions and you lock down everything without leaving humanitarian corridors open, the most vulnerable in the society are the ones that suffer the most. And in some society, women are among the most vulnerable in the society, including women healthcare workers. So if you look at the services women provide, even the community health workers, they provide it to fellow women, vaccination, routine immunization, maternal and child health care. All of this suffered during the lockdown. And we should learn to leave humanitarian corridors open and learn how to control pandemic without shutting down some of the most vulnerable in our societies. Use of sustainable health system and local health solutions. In some countries that have community health workers, all countries, for instance, in Africa, it's more sustainable. It creates more equality when you use community health workers, give them what they deserve instead of bringing a different solution for respond to the pandemic. For instance, let me give you an example. In Nigeria, when the government decided to go use community health workers to perform the work of contact tracing, risk communication, and community engagement, they got better results. And because the women that are doing it are from the community, from the society, and they are trusted and able to go into every nook and cranny and get results. But if you flip the coin over, were they compensated the way you will have compensated an epidemiologist you bring to do the same work and will not give the same effects that a community health worker can do? Finally, one thing we've learned from this pandemic is that we should be prepared to protect and use mental health and other forms of procedures that can be used to build the resilience of health workers as they respond to pandemics. We should not just wait until they've burn out, until we begin to see complications. We should use different methods in which you can intervene and build their resilience as they respond to the pandemic and or outbreak. Thank you. Back to you.
Thank you very much. I think it's really quite remarkable to see the common themes throughout the interventions. Really, the theme was highlighted again and again on solidarity, the importance of keeping the humanitarian corridors open, the importance of building health worker resilience, empowering health workers to take care of themselves in order to enable them to take care of others. And really, this is critical. I'll share just one small example from my region. So I live and work in Egypt, and we are part of the Emir region, which has the highest number of humanitarian emergencies. So really, we saw this issue very much of needing to protect health workers, and not just physically, but also with regards to their mental health, and also the issue of reducing the attacks on healthcare workers. So really allow me to give the floor to Mr. Nunez to respond to some of the lessons that were raised, and particularly address the issue on the campaign that was inaugurated by WHO, stressing that health workers and frontline workers should not be a target. So what would you say in response to what the panelists have raised? What can we do to ensure that health workers are safe to do their job?
I was muted, sorry. After 2 years, I still haven't learned. I would say that for me, let's say the major question here is the question of equality, and the question of treating all health workers, and Dr. Astana said this, all health workers, independently of the occupation they have, as workers that have similar rights when it comes to protection of their safety and their health. And sometimes we may tend to focus on the groups that we think are more exposed to the hazards, and this may be correct, but it doesn't mean that other workers that are sometimes have even auxiliary functions are not also exposed to, not the same risks, but risks that are also serious. And then again, thinking of all the workers and thinking of all the workplaces, and not focusing. We know that there are major differences depending on the public or private nature, depending on the region of the country where they operate, depending on the size. So again, every single workplace has an obligation, independently of its nature, of taking care of the safety and health of all of its workers, and again, independently of the type of contract that they have with them. And this is very important. The ILO and the conventions of the ILO, namely one of the conventions, which is Convention number 155, says that it's the duty of every single employer to ensure that his workplace is safe and healthy for all the workers. And this is something that it may not correspond to practice in many cases. So this would be my strongest message, is that we have to advocate so that, again, there is an equal treatment to all workers in all workplaces, independently of the many differences that they may have in between themselves.
Thank you very much. I want to give the floor to Dr. Astana for you to respond to this point, and particularly on the issue of that was raised by Dr. Abdelaziz on fair compensation, the issue that was raised by Mr. Nunez on really having a fair and equitable working environment that doesn't discriminate based on caste, that doesn't discriminate based on gender, etc. So I would love to invite you to respond to some of these issues and also speak to interventions that can ensure that health workers, particularly women health workers, are safe to do their job. The floor is yours.
Thank you. I really don't have much to add after these two speakers. I think I would just want to stress on the voluntary workforce in India, and which could draw lessons for other contexts where we have voluntary workers, and also the differences in which these voluntary workers, even the state-wise differences or the subnational differences in which they operate, and who has what kind of institutional mechanisms to support. And I think most countries, the resource poor countries, so to say, quote unquote, are still depending on the unpaid and the voluntary work of the health workforce, women health workforce. Though on one hand, they are all voluntary, but they're still performing the work for the health systems, even if they have deliberately chosen to be in this situation for the little money that they get. So I think even if we don't think about the remuneration and safety and consider the voluntary nature of their work, the protection at the workplace should be supreme. It should be non-negotiable that if they meet any kind of violence, stigma, during work, at the time of work, while performing their duty for the health system, while performing the duties that the government is asking them or requesting them to provide, the onus is on the state to provide those safety measures. That should be set, that should not be negotiable at all, and all those provisions should be met. And I think the advocates here for people like us in this community should take this on us to advocate for those rights. Those workers might have their own, have mobilized themselves and raised those issues multiple times, but I think the onus is now on us to take this forward and integrate it with the larger plans. But beyond this, I really want to highlight, I want to take the attention of this panel towards the lessons not learned, lessons still not learned. There's so much that we still haven't learned. We're continuing with these practices. We are continuing exploiting the women and the health workforce at the lower rung of the society as well as the health system. So we need to think, reflect now that what is it that we need to break? What is it that we at least now need to break and not wait for another calamity to fall on us and lose many more lives and so on. Yeah, thank you. Hope this helps.
Of course, we appreciate your contribution. Before we go back to the lessons not learned, which I will ask the panelists to close with a final piece of advice, but I'd like to give the floor back to Dr. Abdulaziz to really give us some further insights on the situation in humanitarian and conflict settings. Because really the issue of health worker safety, particularly for women, as you raised, continues to be an issue that we need to think about, particularly as, again, there's a big inequality in volunteer health workers, predominantly being women, in the issues of compensation and also in the issues of safety. So I'd like to give you the floor if you can kindly respond to some of these issues from your experiences and reflections. Please, the floor is yours.
Thank you, Chair. So it's quite clear that during humanitarian crisis, or even the COVID-19 pandemic lockdown, women are the most vulnerable. If you look, data coming from some countries on the continent shows that during the lockdown, gender-based violence increased, unfortunately, spiked on the African continent. Women that now sit at home, work at home, were faced with more violence, whether even some as very young children were all faced with all of this. So if you look at job losses, employers were more likely to fire women for one reason or the other. And even despite the fact that it's well proven that community health workers do much better in terms of responding in the community for what they do, they were not compensated mostly and were considered to be doing it on a voluntary basis. Who will not want to be compensated for the good work you're doing in the community? So, but what we've done in Africa CDC is to begin to talk about this issue. One, have political will to mobilize decision makers to prioritize the vision and support for community health workers. That's one. Two, policies, including community health workers, coherently across policies and protocols and governance processes and informal norms that will really standardize that cadre of very important cadre of staffing on the continent, and of course increase financing, both increasing and diversifying the source of financing for this cadre of staff on the continent to improve on what they are doing and strengthen their capacity to manage and implement program, the operational component of what they are doing, and they're trying to see how we can increase the quality of the work they are doing, while at the same time protecting them and giving the community health workers a sense of what their career path is. All of this we're working very closely with in the African Union, with the head of states and the ministers. We had quite a number of ministers here, and push this in the end to make the community health cadre, which we know is dominated by women, a formal and operational health workforce on the continent, and responding to the needs of the continent, whether in health security or response to endemic infectious diseases, and even during humanitarian crises and other public health events of concern. Thank you.
Thank you very much, Dr. Abdulaziz, and thank you to all of our esteemed panelists for your insights and your reflections. Really, I think this was a very rich discussion, tackling many complex issues, but also very much highlighting the importance of protecting frontline workers, particularly women, and ensuring safe and decent working conditions. So before we close our panel, and I know we are a bit short on time, so inspired by Dr. Martin Obalo, who started with 4 truths, started our session today. So I want to ask you if you can give us one piece of advice, one word, one truth that you would like to offer an employer on how they can protect their health workers, create decent and safe working conditions. And I already see some of our panelists are appalled by this ask of just one word. So let me start with Dr. Astana. The floor is yours for one word, one truth in improving gender equality for frontline workers.
My one word is listen. Listen to the health workers, listen to your employees, create an environment where they can share what they're going through. So whatever policies are to be devised, the plans are to be made, should be made with participation from them, in conjunction with them. So listen, put on your listening ears.
Thank you. So the one word advice was listen. Mr. Nunez, your one word advice, please.
Not so different. Engage, listen, and involve. We know from the ILO that there are no positive answers, no successful answers without involvement of the workers.
And Dr. Abdulaziz, your one word advice.
Yeah, excellent. So let me build. We've had listen, we have engage, then exert accountability. When things are done wrongly, let's get those who need to be accountable for their actions. When we listen, when we engage, then we get accountability. Thank you.
Absolutely. Thank you. That is a beautiful way to close our excellent panel discussion today. Our top advices are listen, engage, learn, and be accountable. So thank you again to all of our panelists. I would like to give the floor to, I believe, Dr. Salima is back online. So I would like to give the floor to Dr. Salima Rahim to share her experience as a frontline worker during COVID-19 following this very engaging Dr. Salima, the floor is yours.
Thank you, Merit. I apologize for earlier connectivity problem. Greetings, ladies and gentlemen. It's an honor to have an opportunity to speak at this platform regarding safe and decent working conditions for women health and care workers in times of crisis. Being an Afghan refugee doctor, I realize its utmost importance and want to share my personal experience today. I belong to a community where women are marginalized, vulnerable, and it's a male-dominating society. Women are deprived of their basic rights in many ways and are not involved in decision-making. In times of crisis, the rights of women are violated 2 to 3 folds. No doubt the pandemic had hit whole world, but it hit the health system of low-income countries with no reserves the most, and rights of female healthcare workers marginalized. In pandemic, I had an opportunity to work as a doctor in one of the largest public sector hospital, and I found myself on frontline when host country needed healthcare workers the most. I continued my duty in maternity ward and emergency unit with all female working staff, treated pregnant women, delivered babies, and saved lives of critical pregnant women, even those who were COVID positive. We as a team were delivering on average 40 to 50 babies a day. Because workload in our hospital was increased due to closure of private and local setups, the extremely long working hours, shortage of proper personal protective equipment, face masks and shields, and shortage of female working staff, medical equipments led to physical, emotional, and mental burnout among women healthcare workers. Working tirelessly in inappropriate size personal protective equipment for long hours was very difficult to manage. On initial days when safety of COVID vaccination was not proven, pregnant women healthcare workers without vaccination, they continued performing their jobs amid hazard to their health and their baby because our health system was running short of female staff. Most of us contracted the disease, and the death of some of our colleagues has led to more worrisome situation and increased anxiety among women healthcare workers. Here, majority have an additional duty of doing household chores and caregiving of children and family. This was the situation in COVID pandemic, which led which demands that we need to focus more on these aspects and include women leaders while making policies to avoid such situation in crisis. And now due to current economical and humanitarian crisis in our homeland, Afghanistan, women are working in health facilities that are struggling to function with limited facilities and resources. Restriction of mobility and autonomy aids to mental stress and affects the working potential of women health and care workers in a negative way. The uncertainty and unsafe condition creates anxiety and is the reason most of women healthcare providers are reluctant to continue their job. A female nurse who came and visited my clinic told me about her story that she left Afghanistan and her work with heavy heart due to unsafe condition and uncertainty about her job and salary. This is worrisome because we need more women healthcare workers, but the situation demands more sustainable solution and development. Safe environment is necessary to continue working with mental wellness to give full care to our community. Proper strategies, international and national policies should be structured, include women leaders in policy making response and recovery plans to make working environments safe and better for women health and care workers, both in our homeland and host country. International communities should make efforts to raise funds to improve our health infrastructure, prioritize investment in the health and care sector to make environments safe and decent for working. Because decent and safe working environment, mental wellness, and good working conditions are crucial for healthcare workers, especially women healthcare workers, which will enable us to perform our duties well when most needed, especially in time of crisis. Thank you.
Thank you very much, Dr. Salima, for your very inspirational testimony. You've reminded us really of why we're here and why we're doing the work that we're doing, to ensure safe and decent working conditions for women and care workers such as yourself at the front lines, especially in times of crisis. So thank you again. And without further ado, I would like to give the floor to our final speaker, last but not least, to give the closing remarks. Ms. Ambassador Stephanie Seydou, Ambassador for Global Health of the Government of France. Dr. Seydou has been the French Ambassador for Global Health in 2018, representing France in many different international organizations. And as always, very impressive and very happy to have you on board. Ambassador Seydou, the floor is yours for the closing remarks. Thank you.
Well, thank you very much. And it is indeed an honor and a great pleasure to be amongst you today. I am in awe of the power of what was exchanged during this, this session. And I believe indeed that the focus on safe and decent working conditions for women health and care workers in times of crisis allowed us to really hear amazing proposals. And I really want to thank all the speakers for having been so focused and so generous in the solutions, and indeed the very powerful follow-up proposals that they have made. I also want to say that maybe as before, moving on to trying to find a conclusion which would be appropriate and really give justice to the high level of what, and the high level of value which was produced, I believe, in this hour and a half. My first comment, I guess, would be to really greet and congratulate the new members of the initiative. So we heard the Minister of Malawi, also very forceful testimony by the American Medical Workers Association. The African CDC was also a very highly contributive guest in this meeting. Thank you very much, Dr. Abdulaziz. And they come joining the number of long-standing supporters engaged in this initiative. We also had the ILO, Dr. Nunes, and obviously the governments of the very committed countries such as Ethiopia, the DRC, and the United States, last but not least. I really also want to particularly underline the forceful and well, the testimony of Dr. Rehman, which I listened to with great emotion, and I think she really obliges us in sharing this and in really raising, well, basically the necessity to renew our commitments. She's proof, you are proof, Dr. Rehman, that health workers are resilient and incredibly resistant. But of course, we also said during this meeting, it was said first by Lois Pace from the United States, that this must not be at the cost of your own health and safety. I am also very, well, I think that there were very exciting perspectives which were put to the forefront during this event. The Global Health Workers Initiative, which the United States government launched on the 11th of May, and is, I think, an amazing opportunity for all of us to raise to the highest level, as Martin Obalo said in the introduction, our chair, escalate the issue to the highest political level. I think that is a very important new development. I am also extremely grateful to the ILO to have well raised our awareness of this very important new legal framework, which would make it an obligation to all states to enforce indeed safe and decent working conditions for all. And I think that's a very interesting proposal that's made, that this is a necessity for all workers, and all the more for health workers. Of course, the ILO the two conventions, the, let's say, hard law frameworks, which are extremely critical, the Convention 155 and the Convention 190 on preventing violence in the workplace. So just to flag these really interesting evolutions which we have going forward. I'd also like to make a link with what is going on at the WHO, and it's not on the agenda of the current World Health Assembly as such, but as you all know, the discussion on the pandemic, the new pandemic instrument, will certainly open possibilities for these issues to make it into an even broader instrument on health. And that is, I think, something which we can also look forward to going forward. But maybe going back and before closing to what we heard today, indeed, thank you also, dear Chair, for having ensure that we do end up with those very strong words: listen, engage, learn, and be accountable. I think this is this gives us a path going forward. I think we all heard in the lessons learned and lessons not learned, following the words of Dr. Astana, how really the onus is on us, and we have to indeed be able to sort of have this level of collective awareness. I really like Dr. Abdulaziz's call for having standard operating procedures developed in everyday situations, not only in emergency, and his focus on training and on the necessity to create value to reinstate the value of health workers. And then, of course, there was this very strong appeal to make to have a comprehensive and inclusive approach of who are the health workers. And of course, this must include the community and the voluntary work, which, by the way, should no longer be considered as free work, or if we say it in another way, work that the workers pay for themselves. And the value of what they are offering now must be recognized by the global community, international community, national community. And of course, that raises the question of the necessary investment and the necessary recognition of this value, which all of you pointed to. So I have a feeling that, as is always the case with these discussions, value is created simply by putting the issue on the table, and we do make small progress each time, but each time also there is a focus on the urgency, the critical aspect of this issue, and the absolute necessity to keep pushing and going forward. And in this respect, it is great that the ranks are always growing of those who want to keep engaged and to continue to push the issue forward. Of course, we must keep this momentum accelerated in order to ensure that indeed in the next crisis and the current ones, because we talked a lot about the pandemic, but of course there are political crises, the one in the Ukraine, the one in Afghanistan, which was also evoked, but there were earlier ones, and there are ongoing crises all over the world where we know the same conditions, critical conditions of violence and danger prevail, where health workers are particularly at risk. This will remain our reality, so we must indeed continue to accelerate and push forward. And I can assure you that France will remain committed in this regard. Thank you very much to all of you.
Thank you very much to all the esteemed speakers who joined us today, and thank you to all who joined us. We'd also just like to point your attention to the website. All the information on the Gender Equal Healthcare Workforce Initiative can be found on the website. And with that, we'd like to thank you and keep the fight for gender equality.
Thank you. Thank you, everyone. It was a pleasure. Thank you.
Thank you.
Thank you. Bye.